Hello and welcome to In Conversation. I'm James Campbell and I'm delighted to be back with a very special episode in our Fighting for the Soul of General Practice mini-series. As always, I'm joined by my brilliant co-hosts, Drs. Rupal, Shah and Dr. Jens Foell. And today we're honoured to be joined by Dr. Margaret McCartney. Margaret is a general practitioner in Glasgow, working with the NHS Greater Glasgow and Clyde system. And also, in addition to her clinical work, she holds an academic role at the University of St Andrews, where she's a senior clinical lecturer. Margaret, you're also involved with the Centre for Evidence and Values as Healthcare, I believe. So without further ado, let me just welcome you to the show. Margaret, great to have you on. How's it going?
Thank you for having me. It's a pleasure. Great to be on with the three of you. Thank you.
Wonderful. And Jens, Ru, how are you guys doing?
We are living the dream.
I can't quite believe that we're recording this podcast because Patient Paradox was so influential for me. So, I'm very, very pleased to be here.
To start with, though, Margaret, can I just ask you a little bit about yourself? Can you just tell us a little bit more about what your sort of research interests are and maybe what your areas of expertise?
Sure. So I'm a GP, so a proud generalist. I work as a GP partner still. Love my job, but it's increasingly hard to do well. Waiting lists in hospitals are just phenomenal just now. So I think there's a real knock on in the quality of care that we can offer. I'm also a senior lecturer at the University of St Andrews. I'm a late entrant into academia. I had my first academic job, I think 4 years ago, with 1 day a week. And I completed my PhD in 2024, which was in conflicts of interest in healthcare. And that's one of my major areas of research just now, that and together with how we fairly explain things to people, and about the commercial determinants of health and the way they interact with our working lives and impact on patients' healthcare.
Is your research predominantly focused in the United Kingdom, or do you draw upon more international perspectives as well?
Yeah, so one of the things we're doing just now is we're looking to see what kinds of ways have been used globally to try and manage conflicts of interest in healthcare. And one of the big examples of that was the Sunshine Act in America. So I was always a big, and I still am a big supporter of transparency, but I think transparency is only a tiny little bit in a very big ecosystem about how to make things better. And the problem is if I am overly concentrated on one bit, transparency, you might well miss out all the other things that you have to have in place in order to make it work properly.
Thank you very much. That's really great to get that intro. I was also really quite interested to just find out a little bit more about your role as director of the Centre for Evidence and Values in Healthcare. Can you tell us a bit about what that role entails and what kind of the main mission of the centre is?
Yes, I can tell you all about it because I'm very excited about it, and it's just about to launch. So our first event is the 31st of August 2025. No, that's wrong. The 31st of October 2025, and our one after that will be on the 5th of February 2026. And if you're interested, please sign up on our website to our mailing list, and we'll let you know what's on. So essentially, we're interested in ways to help people make better decisions in and around healthcare, and that might be healthcare professionals, it might be policymakers, journalists, academics, researchers, patients, lay people, anyone at all. Everyone is welcome. And we want to look at the ways that we get information, the way we use information, and the way information is explained to us, because we think that sometimes things are both more and less complicated than they can first appear. And I do truly believe that people can take on quite complicated information if it's explained properly and in a jargon-free way. So I'm really hopeful that we can produce something that's of value to people. So our research focus is about trying to help people make and retrieve declarations of interest in meaningful ways and know what to do with that information. We're organising and we're writing a teaching programme for undergraduates, for example, but we want to do something for professionals as well, because we have a massive amount of bureaucracy that doesn't seem to work terribly well. We know that lots of people are trying to work ethically with industry and with commercial factors. How do we do that better? So these are the kind of slightly challenging issues we want to be in. The one in February is going to be about screening, which is really topical always, but particularly just now with PSA and screening in the news. and we're going to look at kind of challenging issues within that. So we're really looking at areas which are difficult. We're going to do one next year as well with vets and dentists, looking at the different types of commercial arrangements that we work in and where the benefits and the risks are within that professional practice. So we're really looking at these kind of slightly difficult and slightly edgy issues, I hope, in a supportive way, with a bunch of really interesting people with different types of expertise coming from different angles, that we can share information and hopefully try and work things out a bit about how we can do as best we can with the good intentions that everyone brings.
Are you sort of curating the areas that you focus on, or do you respond to sort of public demand and things like that?
This makes it sound as though I'm a very organised person, James, that's looking around and working out what to do. So in many ways, I'm motivated by fury mixed with the desire to try and make things better. And that sometimes works in quite haphazard ways, to be honest with you. So so I've got my GP work where I try and do my professional practice as best as I can. I do my academic work, which is a mixture of so a little bit of teaching, some teaching, but also research, and trying to think about the focused areas for that we can get most bang for our time buck. And then we've got the Centre for Evidence and Values, where I'm hoping there'll be a bit of an interface with lots of different areas of medicine, and be somewhere where we can bring the clinical stuff, the research stuff, and the policy stuff all together, and make hopefully a useful melting pot for people that maybe wouldn't normally meet or wouldn't normally come to a university to talk about stuff, a place to do so.
I wanted to talk to you a bit about evidence-based medicine as well, which I know is something that you have a fair bit of expertise in. But I know it's also something that you've been critical of, the notion that evidence-based medicine is, objective and value-free. Would you explain the kind of fallacy and why it sort of matters in practice?
Sure. So I absolutely think that medicine has to be evidence-based, and we saw this particularly during the COVID pandemic, all sorts of people coming out and making wild claims and saying this was evidence-based, but they were cherry picking, just picking bits of research that they liked the look of, ignoring loads of stuff that they didn't like the look of, not looking at high quality trials, just looking at kind of rubbishy trials only, just to support their kind of thesis. So I think that without evidence, like, we may as well be homeopaths, we may as well be doing Reiki. Like, we have to have evidence in order to have a profession. Otherwise, we may as well all pack up and go home. But what I think has happened is that we've become a bit confused about proper evidence-based medicine, and people calling a pastiche of kind of gathering together a collection of kind of innumerate studies and calling that kind of evidence-based medicine. And as well as that, we know that the integrity of evidence-based medicine has been massively undermined by commercial bias, by the non-publication of results, by negative results not getting published to the same extent, by women not being included properly in clinical trials, pregnant women not being included in clinical trials, etc., etc. So it's not the evidence that's a problem, it's the way that we do evidence and the way that we're claiming the word evidence. So I absolutely think that we can't approach evidence just as just as a computer would, without thinking more broadly about what does this mean, what's missing, who's missing, why did we study this and not that, why are we doing more Me Too trials of drugs that we already know we've got good outcomes for, when actually we haven't done any trials, say for people with psychotic illnesses and learning disability, for example. Why are there gaps in our evidence ecosystem, and yet we have got so much research in areas of profit? So we have to do evidence-based medicine, otherwise we will harm people and kill people unnecessarily. But it has to be really good, high quality evidence-based medicine, not something that we're pretending it is.
Do you think there's a real move away from evidence-based medicine just in general on a global trend?
Yeah, I don't know, to be honest, but what I do know is that since the pandemic happened, people have become, many people I think have become less good at critically appraising evidence. So there's all sorts of people that I thought were just amazing at evidence-based medicine, and then they started sort of promoting stuff that was just appalling. And I don't just mean Donald Trump and Bleach, I mean kind of respected academics, and I think obviously the pandemic was a fearful time. People were worried about themselves, their families, and they were worried about, what was happening in the world, and as a result of that, I think a lot of people brought their personal fears, they didn't bring their critical thinking skills to a situation. And I think that echo chambers started to develop on social media. I'm aware of huge schisms still in lots of areas of medicine. where people, I think, have to have probably a truth and reconciliation committee at some point to try and hammer through this stuff. But I just think that we haven't done well enough. Another example is the whole issue about using puberty blocking drugs in children. We knew for years that there was no evidence that this was a good idea for gender confused children, and yet we went along with this because people wanted to be seen to be doing the right thing, or they wanted to be popular, or they wanted to please people, or there was lots of lobbying groups happening. And yet when we looked at the evidence just simply wasn't there, and instead this was very often a symptom of young girls with neurodevelopmental conditions who were being taken down a particular path rather than being looked at holistically. And I think that because we weren't brave enough to look at the evidence and think, well, what are we doing here? Are we actually acting in these in our patients' best interests? We ended up making a lot of mistakes, and it took the CASH review to give us a kind of critical appraisal basically of what we hadn't been doing right over the last 10 years. So I think we're getting evidence still badly wrong. I'm concerned, I suppose, that we haven't looked back enough and thought, what are we getting wrong here? And I'm sure I've been wrong about lots of things as well. I'm not immune.
Thank you very much, Margaret. I was going to bring in my colleague Ru here. I know she's got a few questions for you around EBM.
Yeah, and I think what Margaret says is very reflects what I notice in practice, like when I'm teaching trainees or just noticing what happens. I think that somehow our ability to critically appraise has diminished. In the course of my career as a GP, I don't know if that's just a function of my age, but I feel that it's reduced, that people are kind of grasping for truths, but not thinking, how true is this? People are terrified, for example, about waiting a few days extra to refer someone on a 2-week rule pathway, or thinking that people in their, someone who's got multi-morbid in their 80s should really have an extra medication, and kind of not thinking, hang on, let's look at the bigger picture here. What am I trying to achieve? So that's my kind of personal experience about this. And it's quite difficult to make a stand. I think what you were saying as well about the lack of evidence in particular areas, and I think mental health is the one that springs to mind most, is really stark. Increasingly, I'm being asked to prescribe ADHD medications, for example, and it's not that I have a moral objection to any of this. It's just that I don't feel comfortable about the level of evidence there is for long-term use. And I'm not sure how to kind of respond to all of that as a GP.
I try to respond as positioning myself as an honest broker, or saying, can we afford to think slow rather than pressure, thinking fast, doing fast, fear something needs to happen now. If it doesn't happen now, something bad will happen. And that's incredibly difficult to slow down. Good research or good appraisal skills take time, and it means to get under the data and not just, I've done my research and people just clicked on ChatGPT. That's not research. That's information usage to make your point in a clash of conflict. That's fine, but I find it very difficult to find this time, and also to have the headspace and to analyze the different sources. Just going back to the principles of evidence-based medicine.
One of the dilemmas that we often return to here is translating population level evidence to individual patients. And how do you advise clinicians to navigate uncertainty when the evidence doesn't really map onto an individual's context or preferences? I feel like kind of follows on from what you were talking about earlier, Margaret.
Yeah. So it's our job to give people high quality information, but it's not our job to give people whatever they want.
Mm.
You know what I mean? So it's, medicine shouldn't be a shopping centre. It shouldn't be like a shopping list. So it shouldn't be the case that people can come in and say, well, it doesn't matter what the evidence says, I want X, Y, or Z. In other words, just because people don't wish to accept whatever evidence that there is about something doesn't give doctors a right to open up a private screening clinic and offer whole body MRI scans to everybody, or to do numerous completely non-evidence blood tests on people, for profit, which is what happens a lot just now. now, or to prescribe medications that have no known benefits. So I agree with you. You have to translate population-based statistics or group-based statistics for an individual person, but that doesn't mean to say that you get off scot-free and that you can therefore do what you like. Because I keep seeing this argument being made, particularly by doctors working in private practice, offering non-evidence-based things, who will say to me, yeah, but Margaret, that was a study of people and I've got my individual that I have to look after. But, you know, individuals were part of that group.
Yeah.
You know, and so you can't just say, well, therefore, you know, therefore I'm only going to accept the evidence that I like and I'm going to ignore the evidence that I don't like. That's not how it works, you know. And this argument is made predominantly by people who are working for commercial entities. They're working for activity. They're getting paid for a thing that they do. So the more things that they do, the more in their interest it is to do it. So I kind of find this argument is used a lot there. But then when it comes down to individual decision making, like I think it's my job to say, okay, this is what we know. You know, here are the options that we have, all of which would be reasonable. But this, and this, I definitely wouldn't recommend either because we know they don't work or they're actively harmful. You know, and then it's up to the patient to choose between a selection of reasonable interventions or doing nothing at all if that's appropriate. And it's not my job to tell them what to do. It's my job to help them come to a decision that's best for them. But sometimes there is a situation where it really is obvious what to do and it really is obvious what not to do, and that's quite often in an urgent type of situation. But as Jens was saying, most of the time, you know, things, and Ru was saying, most of the time, you know, we don't have that urgency of making a decision right there and then, and quite often time is something that allows things to become clear. So, you know, that grace of just some thoughtfulness and playing with ideas in your mind can be really, really helpful. But the problem is, if you've got lots of lobby groups at your door who are saying if your GP doesn't do a PSA test on you immediately, they're negligent, and you should demand X, Y, and Z from your GP. And I don't blame patients, I blame the lobby groups who are pushing that message onto patients, who in turn are pushing it onto GPs, who in turn are feeling judged if they don't do something straight away, that they've somehow caused harm to patients. And that just doesn't translate into reality.
I mean, I want to bring my colleagues in again in a second, but just to follow on from what you've just said there, I was interested to ask you, how do you respond to the demands of lots of different pressure groups or lobby groups or charities even, I suppose, who have their own stakeholders and their own priorities? You just mentioned screenings, I think. How do you respond to those challenges and demands?
Yeah, I mean, I suppose there's individual patients who come in and it's not their fault. They think they're following good advice, so it's not on them. What I object to are very well funded charities who have got access to experts that should know about this stuff and are not acting in the best interest of the public as a whole, but are acting in the interest of their charity in particular. And the problem is that the NHS is a cake, and if you take out a bit of that cake, that means that the cake is smaller and there's not much left for everybody else. So unless you make that cake bigger, somebody else is going to lose out by your call for resource or your call for need for that particular zone, as it were. So I think that there should be much more critical appraisal of charities. And at the moment, in some charities are fantastic, but I think there should be much more critical appraisal of the information that's being handed out, because we keep treating charities as always good and for the patient, but actually, you know, I don't think we can assume that. And of course, many, not all, patient groups are funded by industry. You know, so, and they obviously have an interest in making sure that there's pressure being put on NICE or whoever else to promote particular interventions or approve drugs or whatever else there is. So it can be really difficult, I think, to untangle bias in whatever form it is. And of course, we have this inbuilt optimism bias. You know, there's been big systematic reviews that says that both doctors and patients tend to overestimate the benefits of interventions and underestimate the harms.
Thank you very much. That's really, really useful information for us to have. And Jens, let me hand over to you.
I would like to say so much, but I'm asking you as a colleague, how do you say no? And when, and what are your tricks to promote not doing to doing?
I mean, I'm sure I'm not any better. I might be substandard. I might be kind of below average here. But we know there's system things that work. So we know that continuity of care works. So having a trusted doctor that you see regularly over time, if you can organise to do that, that's automatically going to take lots of the stress off. We know that having sort of longer appointment times can be really helpful as well. You know, you've got a bit of time to talk about your fears, your uncertainties, whatever. We know that having stable practices where you can bring people back and follow them up and have conversations, that works as well. The more capacity we have, then obviously the more appointments we can offer, and we can, people are not then stressed that they can't get back to see you to discuss something. So I suppose the system that we work in has got a lot to contribute to how well we can do this. And of course the system then eats itself. So a system that's under stress does more because it's short-term pressures, because you think that you're helping to stop demand by just doing stuff, but then of course that generates more stuff and it goes round and round and round, and we see this all the time. My hospital colleagues are fantastic. Sometimes people in hospital clinics are seen by someone who's not as well qualified as a doctor or a consultant, and you can get lots of work generated that would normally have been absorbed by a doctor at an appointment, but instead more stuff that I would argue are often of low value are done with more referrals elsewhere rather than being captured in one. So rather than putting your strongest resource in at the first contact, you end up creating more work, I would argue, overall.
We've had previous episodes about something called failure demand, Margaret, and absolutely, I think we need to reframe our whole idea about efficiency, in the sense that if you just do something right for the person at the right time, then it kind of cuts out so much turbulence further downstream, but it's really difficult to prove that or measure it because it's kind of unintended consequences, and it's very, very difficult to kind of establish causation, I think. I don't know if you would agree with that.
Yeah, it's a really good question, and it is hard to measure. But I think when we look at patient burden of treatment, that would be a really good way to look at it. There have been a few studies done just looking to see what happens if you follow all the guidelines, and the burden to patients is just massive. It's like a very big part-time job, just to do all the stuff. And of course, the more and more guidelines that you follow, the more and more appointments that you have, the more and more stuff that you have to do. Whereas what you really want as an expert GP to say, actually, for you, in your situation, these are the things that are most relevant and most important to you, and the rest of the stuff probably doesn't matter quite so much. So I would put that to one side for now, and actually kind of work your way in a kind of sensible way through it, rather than just doing a data dump onto people and expecting them all to sort it out.
I feel like those metrics, like patient burden of treatment and clinician time needed to treat, do you think there's any move to kind of incorporating them more meaningfully?
Yeah, there was a great discussion at the Preventing Overdiagnosis conference with some fantastic Nordic colleagues presenting their work on this. And I think, so personally, what I think should happen is that every time NICE make a recommendation, it shouldn't just be about cost of the drug, it should be about cost of time, not just for patients, but for doctors as well. And then think, okay, if you're asking doctors to do this, either you're going to have to increase the amount of doctors in the population, or you're going to have to take out something that doctors do in order to do this. Because what just keeps happening is we just keep adding and adding and adding and adding, and subtractions are very few and far between. And then we wonder why it is that GPs are leaving and feeling stressed and distressed, and they can't do their job and they're working too many hours. It's a stupid system. Like, we're very good at adding things up when it suits us, but not when it doesn't.
No, I mean, even you mentioned PSA, but if to be honest, we've moved to total triage, and if I get a triage request on a Monday, we get 200 and more than 200 triage requests usually on a Monday, and if one of them is I want a PSA, I don't think we've got the resource anymore to do things properly, alluding to failure demand again. So I might well just text back with a booking link, and this is just being honest, because I just don't have capacity to phone and talk it through, or to book an appointment so that they can do that with someone else, especially given that with the prevailing culture, almost certainly they'll have the blood test anyway. So it feels kind of a losing battle. So I'm kind of behaving in a way I don't really want to, but I don't know what other choice there is in a way.
I think that's a missed opportunity for this person. I try not to do that and say, maybe what you need is not the PSA test, but a conversation about life and death is not a bad thing. And not framing this into a test that will reaffirm you, hopefully, that you might live forever when you don't.
So there's a couple of things in that. If this was a properly, or if the UK National Screening Committee decided that PSA screening was a good thing, then it would be a resource screening programme, which would mean that there would be standardised information leaflets that would be tested. There would be helplines. There would be clinics specifically to do this. All that stuff will be done properly. And this is where I blame certain charities who have promoted this idea of telling men to go and get a test done and don't take no for an answer, etc., etc. Because what they've effectively done is set up a system. GPs, of course, can't cope with the demand of every man over 50 is what they're saying to come in. We can't manage that. It's insane to think that we could. So of course, men are going to get care that's that kind of can fit into the day as opposed to the care that they should have. So I would argue that the lobbying has resulted in really poor quality care for men.
I fully agree.
Yeah,
It's asking the wrong thing for people where you might have a conversation about health, but not about the prostate and prostate cancer.
yeah. And we know there is evidence from Australia that says that if men get really high quality information about PSA screening, they're less and less enthusiastic about it. They don't think the government should be doing it or recommending it. They don't think that they want to have it themselves. So their acceptance rate of it comes down and down and down. So, you know, why aren't the prostate cancer charities saying that if there was going to be screening, it has to be done in a really high quality way? You know, it makes no sense to me. It's not good for men.
Margaret, what is your trick in, or I notice we are operating in a very consumerist, commodity-driven environment, but having probably not consumerist values. How can we straddle this? How can we position ourselves as working for the patients, but not in a consumerist paradigm?
Yeah, it's a good question, because I think politicians will very often sell general practice as something they want to improve on the basis of quick appointments with any doctor. And it's a brave politician that says, actually, what we need is continuity of care, stable general practice. We want no kind of sort of, you know, stats that we can use that make us look like we've done something really dynamic with these lazy, fat, overpaid GPs, which is the usual way. And I suppose part of that is I kind of think that there needs to be a different way of making decisions around general practice, the NHS, in terms of policy like this, because it has to be so carefully done in order not to make things worse rather than better, even with more money being thrown in. You know, in Scotland, they've said that they want to do this walk-in healthcare system, and the evidence on that is, you know, to be most generous is mixed, and it fragments care. It's not cost effective. It creates more work, and very often it doesn't get to the people at greatest need. You know, it's very easy to satisfy wants and leave the people who are absolutely the most in need and who've got the biggest capacity to benefit from healthcare to go unseen and unnoticed. So unless you put infrastructures in that can do that, you're just on a hiding to nothing, really. So I think the decision making should be taken out of acute politics, to be honest, and put into a more reflective committee that's asked, you know, so someone can come, a politician can come and say, what is the best way for us to deal with this unprecedented demand in general practice and people complaining they can't get appointments? And then people can go and look at the research and make recommendations and take the political heat out of it, because I feel all the time that was why NICE was set up. You know, it was to take the political heat out of decision making of what should be funded and what not. If you remember the Cancer Drugs Fund before that. So and the UK National Screening Committee, it does the same thing. It is so what Rishi Sunak should be saying is, I think men should get the best possible treatment for prostate cancer, and I'm going to ask the UK National Screening Committee to review the evidence and report back. And that takes the political heat out of it. What you're saying is then, I want expert opinions and advice to inform policy, rather than saying this is what I want and you can come up with it. You should come up with the evidence to prove it. That's not how to do science.
Can I just pause for a second and just ask, just Margaret, if you wouldn't mind just explaining what NICE is, just because I think there might be a few of our listeners who aren't too familiar with NICE.
Sure. So NICE is the National Institute for Health and Care Excellence, and it was launched because, well, there was a few different reasons, but it was launched because there needed to be a way to fairly decide what the NHS should fund and not when it came down to, in particular, extremely expensive drugs. And there was this kind of postcode prescribing where some people in the country could get access to some very expensive things and others couldn't, just because of where they lived and local decision making. So the idea was that this would be done in a formal and national way. So all the evidence is fed in, it's looked by expert committees, they try very hard to be as unbiased as possible, and then they make a judgment, best case judgment based on, how good they think an intervention is. And that's meant to take the sting out of decisions not to fund things, that it's been done in a fair and transparent way. everybody, and everyone gets a chance to feed into this. Patient groups that I was saying earlier, also academics, researchers, experts are appointed, the chair is non-partisan, etc., etc. And there's a similar one in Scotland called SIGN, Scottish Intercollegiate Guidelines Network.
Brilliant. Thank you so much for clarifying that. I really appreciate it. So I wanted to ask a question around uncertainty and not knowing, which are obviously uncomfortable, often for clinicians and for patients. So I was just wondering, how do you reason with clinicians and patients about areas of genuine uncertainty, especially when people are expecting firm answers, perhaps again because of different pressures and external stakeholders and things like that, telling them that they can demand these answers when in fact there might not be evidence for you to provide them?
Yeah, I find this really interesting when you go into like longevity websites and stuff, and people are kind of trying to kind of, you know, game all their numbers and do lots of things because they want this certainty that they're going to live like forever. I find
Yeah.
that fascinating. I find it really, really interesting, just, you know, what people think they're buying with all this kind of stuff. So I'm a great fan of Simon Singh, who wrote Fermat's Last Theorem, one of my favourite ever books. And in it, I learned very much what it meant, the difference between mathematical proof and scientific proof. So in maths, you have a proof and it stands forever. You know, you've proven your thing and that's it. You're in the history books. You are immortal as far as your proof goes. It's set in stone. But when it comes to science and medicine, we don't have that level of certainty, and we're never going to have that level of certainty. But actually admitting that uncertainty is really helpful, because if we're going around saying that we know, we would still be putting babies to sleep on their front, and they would still be dying unnecessarily of sudden infant death syndrome. We would still be doing you know, harmful things like class 3 specific class 3 antiarrhythmic drugs for heart attacks, because, you know, they seem to stop VF. Therefore, why wouldn't you give them in heart attacks? Well, when you did a randomized control trial, more people that got them died. So uncertainty can work in our favour, because if we think, maybe I don't know this, that enables us to test our uncertainties and to try and reduce them as much as possible and make the care that we give as good as possible. So I don't really have a problem with uncertainty as a whole. What I have a real problem with is unhelpful, unwise or untrue certainty predictions when they just don't exist. And we do this all the time in general practice, you know, saying to people that I'm pretty sure this is what you've got and I'm pretty sure this is what will happen. If this happens or this happens, well, I'm probably not so sure, let me know. And when I started off in general practice, I would be really embarrassed that I couldn't tell people exactly what the problem was and exactly what was going to happen. And now, like, you know, I have no shame. I Google things in front of patients. I look up guidelines all the time. I double check prescribing quantities or numbers. I print stuff out all the time. You know, as I've got older, it's kind of got easier and harder, but also easier.
It's interesting. Do you find that you say, you know, with Googling things in front of patients and being more transparent and open about your own process and how you're coming to, you know, decisions and how you're kind of assessing them, do you find that patients are more open to that way, or do you think they come in expecting, well, hang on a minute, what do you mean you're going on Google? I mean, don't you have the answer? And, you know, do you find that the patients' perspectives are changing?
I wouldn't know, you know. I think you would have to ask people in an anonymous environment and what they thought or not. But you know, I'm not just putting in like symptoms and Googling it. It's things like, you know, SIGN guidelines 2024, you know, blah blah blah, azithromycin, COPD. Do you know what I mean? It's kind of like looking for specific, you know, it's focused. It's not hopefully I'm looking for something specific that I know I've read or I know is there or I know whatever. But then sometimes there are things, you know, a specific antibody that I want to check for somebody who's got a sort of an unusual family history of something, and I can't remember what it was, and I'll look it up. So yeah, I don't have any qualms about doing that really, but I don't know what the impact is on trust, because you could see that trust could be wrong, you know. So you could trust a doctor that always said, I know the answer, don't argue with me, I'm completely correct, you know, I'm supreme, you know. That doesn't sound like somebody really great to trust overall, does it? So
No, it doesn't.
But some people might quite like that, you know. There are some, you know, you can see how some people might be reassured by, you know, the myth of the great man sort of thing. So I don't know, probably it's different strokes for different folks, probably, I don't know. But I think the good thing about general practice is the mixture of people that work in it. So you hope that people can find a doctor that they get on with and who shares the same kind of broad perspective as they do.
Oh, thank you for sharing that personal take on that as well. Jens, let me come back to you.
Yes, what is your take on using bots to do all the data trawling and instructing them to use certain data sources, let's say NICE guidelines, and to doing a systematic review as NICE would do it. Do you have experience with speed NICE guidelines at the tip of your finger using a Margaret bot?
Do you mean like using ChatGPT or something?
Yeah, or DeepSeek or anything like this. And some people are quite slick in setting the right instructions, and I see that as a real opportunity to use research data to make decisions. On the other hand, it can be a power tool to influence, etc. So I'm truly ambivalent, truly open in this respect.
Yeah, I think a bit of ambivalence is probably no bad thing. So interestingly, my children get really annoyed with me if I ever am using ChatGPT. They think it's really bad. Yeah, they think it's really bad. I'm feeding the algorithm and I shouldn't be doing that, and stop it. So I'll tell you twice I've used ChatGPT. Once was last year. I was doing my appraisal. I really hate appraisal. No evidence for it. Can't stand it. Waste of my time, and waste of my appraiser's time. So I thought, give me a clinical incident of something that went a bit wrong, but make me look quite good. Okay, at the end of the day, and it was just such an amazing reflection and everything. I just couldn't put it in because it was just too good. So that was the end of that. And then the other one I did was I asked ChatGPT, should I buy a new bike? And not only did it tell me to buy a new bike, it told me to buy the most expensive new bike.
Yeah.
And I was an amazing cyclist, and why did I not have at least 6 bikes, etc., etc. So I kind of think maybe it flatters beyond what it should. But so it's, at the moment in my practice, if I want to switch between the practice GP mailbox and my own personal one, I have to turn off and on my computer, because there's a glitch in the system that I haven't been able to fix, and I haven't been able to get IT to fix, even though they've tried. And one of my colleagues having to do that as well. So that's happening 3 times a day. At the moment, I have no way of finding out which of my patients I've asked to get blood tests done, where the results haven't come back to me for whatever reason. So there's so many obvious things that some technology would help with, and yet we seem to be aiming for this really complicated stuff. And I would rather, as I keep saying, have the great big underwear garments of IT proper in the NHS before we start doing the fancy stuff.
I think that's a really important point. We did have some really interesting conversations around AI and large language models and how it may help the healthcare profession, but also there was a lot of fear and concern as well. But I think what's happened with ChatGPT in this instance is it's probably cracked into your Strava account, it's in your PBs, and it's just it's giving you the advice you needed all this time. You really do need that 10,000.
I know, I bought it, James. There was no hesitation. I was like, well, yeah, clearly.
If the tech says so, maybe you've got to take that leap sometimes. But Ru, let me bring you back in here. I'm sure you've got a question for Margaret.
I mean, in this kind of context of increasing interventions, I mean, it's multiplying, mushrooming, isn't it? How do you think we should best respond, like looking forward 5 years or any length of time, really?
Yeah, I mean, 10 years ago, I have to say, I was really thinking if we didn't act now, the NHS was just going to sort of just be kind of fragmented, destroyed. And I have to say, my heart is kind of breaking. It's kind of broken really over it. I am aware of someone who was under cardiology in Paisley in Glasgow in their 80s and has been given an appointment in 2 years' time to see a cardiologist. People who are referring for urgent suspicion of cancer meant to be seen within 2 weeks, 5 months, 4 months. So, I think at some point we just have to say, well, it is broken, and it's appalling. It's appalling, and it breaks my heart, because the people are the thing that really makes the NHS, and the people that are still there. You get people now in their 80s who would never have dreamed of going private in their lives, and they're basically saying, my kids have said just spend their inheritance on their hip replacement, because they can't wait another 3 years or however many years for this, and they're in pain every day, and they're hoping to get another holiday abroad or whatever. It really is soul destroying, I think. So in some ways I think it's less about can the NHS be kind of saved. It's more like, is the political will there for everyone to get a decent basic standard of care from the NHS? And I'm not sure that it does. And the more I see, plans for fragmentation, more sort of gimmicky type of stuff, it really concerns me that the will really isn't there to do the basics right. And that's kind of what I'm meaning about trying to take it out of party political policy making. And I know decisions are always political in the end here, but all the parties agree that the NHS is a good thing. There's no party that wants whole-scale decimation of the NHS, and nobody says that in their manifestos. They all say that they want a strong NHS. So are we prepared to put aside party political differences and try and work out the most evidenced, best ways of trying to make it functional again?
Thank you very much, Margaret. Powerful statement. Jens, Rue, did you want to add anything to that? Maybe your own perspectives?
It sounds so good, but I think it's impossible, because I've been on NICE guidelines for chronic pain, and with every topic there are so many commercial and power and so forth conflicts of interest. So I don't see a way of having it outside a political arena. I'm longing for such an Habermasian perfect democracy for everybody, but I don't see it. I mean, I think I'm a nihilist or Foucaultian dark guy. I don't see it. I want to see it, because I see that the NHS runs on caring all the time. People do irrational good stuff because they care and love, because this is strong. But somehow it's all calculated, and there's a horrible culture of coldness in there, decorated by numbers. So I don't see the accounting and the love in the right way together, and I'm looking for that.
Yeah, no, I don't know that I've got much more to add. I really agree. I think that we have to act like this isn't a theoretical argument. We have to understand that resources are limited and how we want to apportion them, and not just be seduced by this, by pressure groups, by kind of thinking that every single intervention that we can possibly do is worth doing. I mean, I've been very influenced by Iona Heath's kind of discourse about sufficiency. At some point, I think it's an uncomfortable topic, but we can't avoid it.
Margaret, any thoughts on sufficiency?
No, I think Iona calls it lagom, doesn't she? This kind of idea about just having enough, and I agree. The problem is that with so you've got these you've got your pushes and your pulls, and the pushes are all the lobby groups, industry, commercial determinants of health, all the rest of it. So, but then what are you doing to kind of pull back from that? Where are your protective factors? And it used to be we would have checks and balances, I suppose, within the NHS. We couldn't do certain things, or there was kind of boundaries or barriers between stuff. One of the things that sometimes happens is that people don't get the answer that they like from the NHS, so they'll go to the private providers and then come back into the NHS expecting all the other stuff to get done that they don't want to pay for. And we can't really deal with expectations like that, that are not evidence-based and are not of benefit to the patients, because quite often they're about commercial entities making profit rather than anything else. And I really think we need to have stronger regulation about that. But I don't know who's got the impetus to do it, because as Jen says, where is that motivation just now?
I was going to just sort of round things up by looking ahead, and you've touched on this a little bit, but what changes in the way that we sort of generate, appraise, or use this kind of evidence-based medicine would you like to see over the next kind of 10 years or more? And do you foresee a kind of like reforms to EBM that are more grounded in values and pluralism and perhaps the patient context, or is that not necessarily feasible?
So I absolutely think that we need to have evidence-based medicine, but evidence-based medicine done well. So it's more about getting the quality up, and then it's about really strong critical appraisal. And I think we could all do that. And I think that the ability is there. The ability is not in doubt. It's more just getting the time and space to do it, and then being able to carry through with it. So, like Rue was saying, like she knows about PSA and the problems of it and all the rest of it, but the resource isn't there to actually go and have that discussion with men, to fairly inform them, etc., etc. So you can have all your critical appraisal, mental skills, but unless you've got the resources to actually enact that, then it's not going to help. So I think that if we're going to have EBM done effectively, it has to be from the start to the finish. You can't just resource the beginning of it. You have to resource it all the way through to the end and enable people to do their job properly. And that's what you were saying about, you know, the time needed to treat in terms of, you know, medical activity. You know, all of that has to be factored in. You can't just expect people to miraculously create, you know, new time zones. You'd need one of those Harry Potter time traveler necklaces to try and do that and make more hours in the working day. And obviously we just can't make that happen.
Thank you very much, Margaret. I really appreciate that. And Jens, Rue, do you have any final questions for Margaret?
No, really well said. Thank you so much
Yes.
for joining us, Margaret.
Thank you for having me.
Yeah, just to say thank you, Margaret. That was a really, really wonderful point to finish on. And thank you so much for your time today. Thank you so much for joining us in conversation. It's been such a pleasure and really, really informative.
Thank you for having me.